Thanks for joining us for DermTube daily coverage from Maui Dermatology. With us is Bruce Strober, who's the Vice Chairman of Dermatology at the University of Connecticut, and he's going to walk us through his presentation on psoriasis.
So today I was talking about, in my session, about apremilast. It's a new medicine approved about 3 months ago for moderate to severe psoriasis. Importantly, an oral medication taken twice daily, morning and night, 30 milligrams. There's only one dose. And I described in brief its efficacy. About a third of patients achieve what's called a PASI 75. About 50 to 55% achieve what's called a PASI 50. And more or less it's what I'd call a quiet medicine. In other words, no laboratory abnormalities associated with it. Really, blood test monitoring is not a requisite of using the drug. We do need to be aware that some people have some intolerability to the drug, namely nausea and diarrhea, but it's a rare person who stops the drug because of those issues. And finally, there's a fraction of patients who show some weight loss while on the drug. About 1 in 5, 1 in 6 patients have some measurable weight loss, more than 5% of their body weight. Therefore, there's a few issues such as weight loss and intolerability that need to be discussed, but it's about giving the drug and allowing 2 to 4 months to see whether a patient has benefit.
So over the past few years where we've seen a host of systemic medications get approved, how do you conceptualize this in terms of our armamentarium for treating patients with psoriasis?
To be clear, we're really in the midst of a renaissance because not only are we seeing drugs like apremilast approved, but we're going to see 5 additional biologic agents approved over the next 3 years. So as I said this morning, in 2018, there might be 15 or 16 approved systemic drugs for moderate to severe psoriasis, many of which, some of these newer biologics, particularly IL-17 inhibitors, IL-23 inhibitors, achieve extraordinarily high efficacy. Apremilast, being an oral medicine with little monitoring, sort of is a set-aside alone medicine. It doesn't have an injectable approach. It is something with which patients are familiar, oral medication. It is lower efficacy than the biologics. It will be a drug used in practices perhaps as an entry drug for patients who don't want to do injections. Though its low efficacy might mean that patient eventually becomes a biologics patient.
So in terms of time frame where people have actually been on these medications, can you tell us a little bit about the FDA studies and time frames of a lot of these things so that we know and anticipate communicating to our patients about how long studies have actually shown or continue to show efficacy?
Well, apremilast is a new drug, and therefore we have less experience with it. So new drugs, invariably, we have just clinical trials data. Apremilast has, in the neighborhood of a few thousand patients being on drug 2 years. All right, compare that to a TNF inhibitor, where we have many thousands of patients across many indications who've been on drug 5, 7, 10 years. So the level of support regarding long-term use and safety and efficacy is much more robust with older medicines. Apremilast is going to have to go through the usual experiential maturation. More and more patients go on it in the clinic. There'll be registry data. There'll be long-term studies funded by the company that makes it. It just takes time to get increased comfort. This will be an ongoing story, especially with all the new drugs.
So in terms of these clinical trials, have some of the things that are associated with exacerbations have been removed, for instance, smoking and obesity and those types of things, or do we know that those patients can respond just as well to these medications?
It's a good question. I mean, the ultimate question is, do we know when we look at a patient at baseline how they're going to do 6 months from now? And really, we don't have that yet in any reliable form. For example, apremilast, a heavy patient doesn't do better than a light patient, or vice versa. Or a person who smokes doesn't do less well or more well than a person who doesn't smoke. So essentially, you're always, as I say with patients, in a trial and error mode. We try this drug, and if it works, we stay on it, and if it doesn't, we move to the next. But we have no way of knowing at the initiation of therapy what's the best drug.
So in terms of a therapeutic ladder, Would you be incorporating this along the spectrum of after topicals seem to fail, but before you get to something traditional therapy like methotrexate?
I think for certain patients that's definitely reasonable. Patients who fail topicals, who have 5 to 10% BSA, yet you'd think are moderate to severe, who don't want to do a biologic, who don't want to do methotrexate, and who have a payer, an insurance plan that can cover apremilast. That's a big point of it. Yeah, they could be introduced to apremilast as their first systemic therapeutic.
Thanks so much for joining us for DermTube Daily Coverage from Maui Dermatology.